Hey, guys and dolls. Before we jump into this episode, a note about our content today. This is created for adult audiences only. We advise listener discretion. So if you need a breather, take a break and come back later. This is your Pain Game podcast, where we talk about the game of living in and with chronic pain and trauma, getting to the heart of how to heal. I am your host, Lyndsay Soprano. On the show, I plan on discussing with doctors, chronic pain patients, holistic practitioners, loved ones, and anybody that is interested in having their voice heard in the chronic pain and trauma world that we live in. Sometimes I wish that I lived with an anesthesiologist because I really feel like I need a hot dose at night to help me sleep and get through the pain that seems to just rise slowly and uncontrollably at about 7:30 to 8 p.m. every single night of my life. And it doesn't allow me to sleep. And as a busybody that I am, even in the pain that I am, because everybody knows that I'm just a wild child, and even still, you would never guess that I feel the way that I do, because that's who I am, right? I'm a bite on a stick chick when it comes to my pain. And, it's getting old. And I have avoided opiates and pain pills entirely for the past decade of this, right? With my CRPS and now, of course, all the other Lyme disease and all the other BS that's going on with my bod. Because I just will not go down that road. I know myself too well. I have an addictive personality. I have addicts in my family. I've struggled with addiction myself. And the last thing I would want to do is add opiates into my world because I would LOVE them. And I don't want to end up being a statistic that my sweetie has to report on because he's in broadcast journalism, right? I probably would make the news because of him. So what other roads can we go down to help better manage our pain and improve our overall health? Because, almost every road I've been down with our healthcare system and pain doctors has not been ideal. I've been cut open and sliced open, emergency surgeries and pills that don't work. I mean, how many times have I been on gabapentin? Give me a break. It's insane. So what can we do here? What can we do better to communicate with our doctors, to communicate with our healthcare practitioners, and also to communicate with our family members and our friends, because they're part of this too, our pain journey, right? Journey, that it is. So today we'd like to talk about making some small practical changes in our daily lives that can empower us in our pain community. And that is a community, guys. That's what we're here for. It's not just me going through pain. It's not just you going through pain. It's our loved ones. It's the people we work with. It's our best friends. It's our nieces, our nephews, our children, our dogs, for crying out loud. Certainly one of mine. He's my pain puppy. We affect everybody, right? So here we are. We're here to empower you, of course, but empower me a little bit too. But I'd like to introduce you to our guest today, Dr. Sarah Merritt. Hello, darling.
Hello. Thanks for having me.
Oh my gosh, it's so wonderful to have you here. Dr. Merritt is a board-certified anesthesiology, pain medicine, and addiction medicine practitioner. Alas, why I wanted an anesthesiologist to put me to sleep. Her private practice is right outside of the Washington, D.C. metro area in Baltimore and Bowie. And she's a huge advocate for patients. Advocation, and empowers, that word that we talk about so often on the show, to empower us and her patients to get the most from their relationship with their pain physicians, as well as other doctors, healthcare providers, and family alike. She has extensive experience in management of acute and chronic pain, as well as the diagnosis and treatment of opioid use disorder. All right, so I'm rolling out the red carpet for you, babe. I'd like to get started by talking about how you got started in pain management. What brought you to it? And then let's take it from there.
Yeah, well, I think I started with just wanting to be a doctor. And as a kid, I really, just having a good relationship with my own practitioner. And so it really wasn't until I got into medical school that I thought oh, now I have to decide which type of doctor that I want to be. I did not know that I wanted to be a pain doctor when I started. And getting to work with patients who have a serious pain problem, on the one hand, that can be kind of heavy and it can be a turnoff. And not, honestly, not everybody wants to do it.
No, we're a tough group.
Yeah. But on the other hand, if you help someone with a serious pain problem and you really help them, then you've helped them with their worst thing. It's a big deal, and it feels good. And, for me, building those relationships has been a really gratifying part of being a pain doctor. And so some of those patients that I've worked with, over years, and we've been able to either make progress or help them hold steady or help them maybe not lose hope might be, even just enough to feel like you're accomplishing something.
Yeah, and hope is a huge thing. Every episode on the show with a message of hope. So when we get there,
Yeah.
that's your homework, we're ending with a message of hope. But I mean, because it is a very scary and lonely place when you live in pain. And over the past couple of weeks, my pain has like skyrocketed to the point that my sweetie is like lifting me in and out of the shower and helping me, which is new, which I don't care for.
Mhm.
But here we go. We wake up and we keep on trucking. Is it easy? No, it is not. But I am hopeful. And I am hopeful because I meet people like you. So let's talk about what you do in your practice for people that live in pain. What do you guys do?
Yeah. So my practice in many ways is similar to other pain doctors. As a medical doctor, I can prescribe medications. I can also do things like injections or, we talked about like the implant type of treatments. We offer those type of things in the practice. And then one of the other things we do in the practice that's been really impactful for some of our people with significant chronic pain is ketamine infusions also. So really, in a nutshell, medications and injections are the unique things that maybe only a physician or medical provider can do. But then those are not the only things that work for pain or for chronic pain. And so obviously, we make a lot of referrals to other types of providers. So things like physical therapy, occupational therapy, and working with patients to incorporate lifestyle changes possibly into their world also.
And I know within pain, with myself specifically, I can speak to myself and as well as some other people in my pain community, is nutrition is a huge component of it too. I mean, for me, my problem is actually eating because I'm so nauseous all the time from pain, right? And we've talked about this ad infinitum on this show about the importance of nutrition, not just an elimination diet.
Yes.
Because I've eliminated everything. I'm like, everything you've asked me to eliminate is gone. What do I need to add?
Yeah.
Yeah. So now I'm like, great, I don't do any of that shit in my body, but now what am I supposed to put in it? And we get, with all of the diets, it's like paleo and keto and this and that. And it's like, it is so complicated. And I feel like there's ways that we can possibly simplify that. But within your practice, when it talks to, I think you do a lot about education on the best things for you. And that is something that I have lacked with pain doctors that I've worked with. But I have been to so many pain doctors and they spent about 17 seconds with me.
Mm-hmm.
And I'm like, here's my list of the things I've tried. I've done this, I've done that. Here's my thing. Here's my synopsis. Do you think it can help me? And instantaneously, with, I would say, 5, 6, 7 pain doctors, every single one of them was opioids or spinal cord stimulator for me. I was not a candidate for injections. I don't necessarily believe that may have been true. So I think the educational part of what you do is really cool. Can you speak to that a little bit?
Yeah. I think, and sometimes it's even helping the patient help themselves, right? And that's the empowerment, right? Like I can't do your elimination diet for you. I can point you in some directions. Or sometimes with patients, like if, maybe this is a different situation, but I think there are parallels and it comes up a lot. If there are patients who need to, say, lose weight, right? Like we can talk about weight may be a factor in your pain. It's probably not the only factor, but if we can optimize you, maybe we can optimize some of that pain signaling in the body. If you have enough fat that there's excess inflammation, maybe we can help improve that. And a lot of times that's such a process. So in terms of like weight loss, right? There's no one magical weight loss diet that works, right? If that's the person's challenge. We don't have like one diet that works for everyone, right?
Everybody is everybody. We are our own little system here. We're our own personal universe.
Yes. Your own personal universe. I love that. And so I think it's the same for the pain patient who might be exploring just from a standpoint of, are there dietary things I can do to improve my pain level? Right. And so there are people for whom going gluten-free will be really impactful, or that low FODMAP diet might be really impactful, but it's not going to be the same answer for everybody. So for me, really in that meeting with the patient, very often I'm just trying to maybe acquaint them with those ideas, and also, walk that line of like, I'm not exactly saying that, the ideal diet will fix every problem, but that it may be worthwhile, because like, if we get to where, hey, I've tried a bunch of medicines, I've tried a bunch of injections, and I'm feeling kind of stuck, it may be that that's kind of what there is digging deeper and diving deeper on dietary factors, lifestyle factors, et cetera.
Yeah, I mean, what you put in your body is a huge component to how we feel. I mean, think about Thanksgiving. Everybody eats so much food on Thanksgiving, and we all fall asleep and feel like crap.
Yeah.
Because we're so full. That is what our body's response to what we just put into our bods, right?
Yeah.
And I experience that there are days that I am not perfect with my nutrition. I'm actually far less good about nutrition, only because I don't give myself enough.
Mm-hmm.
And that's for a different show. But it is definitely a challenge, because when you're dealing with pain and you're dealing with the nausea that comes from pain, and you're dealing with, well, everybody's told me to do this and none of that works, that hopelessness, that loneliness that comes with pain, especially when you're alone at night with it. So within your practice, when you've got people that come and see you, do you have a lot of patients that come to you that have used opioids, that are dealing with opioid addiction issues that you work with?
That does happen sometimes. I mean, so we have kind of a branch of the practice where we see patients for addiction specifically. And, the patient might acknowledge, hey, I've been using or overusing medication or street drugs even. And that might be totally separate from a pain issue, right? Because you can have both, right? You can have pain issue
Absolutely.
and also a separate kind of addiction issue.
Yeah, and pain also can be mental pain as well as physical pain. And I think where there's a blurred line is between, a lot of opioid addiction comes from a lot of mental health issues. And then it may have come from an injury that got started, and then the injury's already resolved itself. And now they're addicted to this, and now they've got this other problem. I mean, I read about it all of the time. It's such a slippery slope.
And in fact, the thing I would share is a little statistical info. So 20% of Americans would tell you they have some amount of chronic pain. 20%. That's a lot.
That's a lot.
A lot of people have some amount of chronic pain. And there's 8% of Americans have high impact chronic pain. And so that 8% is people who, are maybe disabled or need significant daily medication. And then I think the number is maybe more around 3% who maybe take a daily opioid. If you ask people who are in treatment for opioid use disorder, if they have chronic pain and or did they have it before they started using opioids, that number is like 40 or 60% of those people will say they had pre-existing pain and that it had to do with them starting to use opioids.
Yeah, I mean, absolutely. I remember there was a girlfriend of mine who just had just this incredible chronic back pain. It was just debilitating. And she ended up, after getting on opioids, she ended up getting the pain resolved in her back, and then ended up like Skid Row style. Just didn't, the pain was gone, but now she entered into a whole different kind of pain.
Yeah, it's a tragedy. And
it is. It's very sad. And we hear about, of course, in the news, our opioids, especially here in the United States.
Yeah.
It's a scary place when you live in pain, because you get so desperate. And that desperation is something that, coupled with CBT and coupled with other strategies and nutrition and having a good support system. I am so fortunate that I have an incredible support system. And I don't think that I am in the majority.
Yes.
I mean,
I think that's
and I am grateful. So to everybody that loves me and supports me, thank you. But it is just like one of those things where I have girlfriends and friends and all of these people. A lot of this happens with women more than men, at least in my experience. We take on the world, getting down to the root of why we feel the way that we feel, and the reason why we're alone and all of this. I mean, God, there's so many things that I can talk about with in regards to this. I don't want to go on my own slippery slope on that too.
There's a lot.
There is a lot. And
I think for people with a high level of pain, right? And say, for instance, in your situation, okay, I have a high level of daily pain. I'm not necessarily taking an opioid medication. And I do find, in the healthcare world that I work in, if I hear the experiences of patients like yourself, going to a doctor or going to the ER with these big complaints of pain, healthcare providers, start to conflate that with like you're asking for an opioid, right?
Oh, absolutely.
And as a patient, it's important and helpful for you to be as clear as you are about, hey, here's what I'm experiencing and here's what I also maybe don't want, if you're in a situation where you're like, I'm not asking for an opioid, and getting really clear on that, I think can be helpful for the team.
Yeah, that's a good tip, because one of the things that I have made absolutely abundantly clear whenever I have met with any doctor, any general practitioner, anybody that's working with me in my health and my bod, I always am like, I will not take a pain pill. I am not a pain pill seeker. I will not do that. That's not my jam.
Mhm.
But if I need to, under an emergency situation, need something, what do we do? Because, for example, this is a good example, because like I mentioned earlier in the episode, I could not physically put my feet on the ground. Like, there was absolutely no way. So I'm rolling like a corn dog in my bed onto an ottoman into my wheelchair, and then getting on the floor of my bathroom. And then my sweetie is lifting me and putting me in the shower. And he's a big pharma guy. He loves it. He thinks it's great. He's like, Lyndsay, you seriously need to consider at least having something here on these kind of days.
Right.
What are your thoughts on that? Because such a scary thing for me, and I don't want to ask. I don't even know the right questions to ask without doctors thinking that I'm seeking.
It's tough. I mean, I think I would maybe share a little story, almost like, so here's what's not exactly true, is like what doctors or what the OxyContin folks were saying in the 90s of like, well, as long as you're taking it according to your doctor's direction, it's no problem.
God.
And there's no way you'll develop an issue, right? Okay, we all know now that's not true.
Yeah.
Or if you take the long-acting medicine, well, those aren't really habit forming. Well, that's probably not really true either.
They also say Ambien isn't habit forming.
Yeah, your body can get very used to that. Yeah.
Yeah.
What I would say is, I treat patients, and there are people who are able to use an opioid medicine on a sometimes basis. But I would also respect, the patient who really knows themselves, who's like, I just don't think that's good for me. Okay.
Yeah.
Well, it's worth a discussion. That is one of the options. That doesn't mean it's the option for you. I do have patients that will sometimes have, a small amount of medication that's for, emergencies, and it might be something they might need a refill on once a year, almost like, there are certain headache medications that, maybe some neurologists or some pain doctors will give, a small amount of once a year just for those emergencies. As long as the patient can manage that, I think that can be a reasonable option. But it also doesn't have to be an opioid medication. I have patients who can use, certain muscle relaxers like that, or even like a high potency anti-inflammatory like ketorolac or Toradol.
Two medicines I've never heard of with all of my years, right? And so this is exactly my freaking point. Yeah. You giving us tips on questions that we need to ask, and also expectations that we have for these doctors that are like, well, do all of this, and this is what you're supposed to do. Well, you're the doctor, so you know everything. I'm like, wait a second, I know me better than you will ever know me. And that is not something that I want to do. That's not the path. So can you talk to us about alternatives to opiates? Because that is like, ding, ding, I'm in.
Yeah. So I think, with patients, talking through, if I'm seeing a patient and you say, hey, I've never heard of either of those things. Okay, well, ketorolac or Toradol, the Toradol is a intramuscular injection a lot of times, and people give it in the ER, and it has pretty good data. Sometimes doctors will quote that like Toradol is equivalent to 10 milligrams of morphine, like in its potency, like in their studies when they tried to compare, like, is it effective? Yes, it's quite effective. It's super effective, but it's also kind of rough on the kidneys. And so it's not a daily medication. And then to your point about like, I'm having a horrific day, I'm not able to get out of bed. Okay, this is looking like a Toradol day. Let me see how
Right.
this goes and try, maybe a dose of something like that and see if it could be a difference maker in terms of moving things in a better direction.
And is that something that's prescribed? Like I give myself a shot. I know, I'm sorry, we're getting a little bit myopic here, but I'm
Sure.
just curious because I've never heard. I mean, this is insane.
Yeah, not every doctor
It
prescribes.
drives me nuts.
Yeah.
I am like, this is where we get so lost in this, because it's like, you're going to do this, do this, because this is what I'm used to doing, and not exploring me as a woman and my body and where I am in perimenopause and all this other stuff that's going on and how that all works together holistically.
Yeah. And I think that's the frustration that many of us have with the healthcare system, obviously, is that, we're really not reimbursed very well for the time that we spend with patients.
Hey, you guys are doing a bunch of paperwork.
Yeah, it's tough. It's really tough.
Yeah.
And I actually, enjoy spending time with patients, but it's tough because it's hard to balance the needs of like, okay, well, I need to see enough patients that, that we can support my staff and support what we do.
Right.
But then I also want to like spend enough time and be impactful in those conversations that we have. So it's a balancing act for sure. And, we try to find our way. But I think it's true, so it's easy to, for on the doctor's part, on the provider's part, to like write a prescription, send the patient on their way. The prescription is the intervention, right? And it's standardized. And so we can know like, oh, well, scientifically, we know that this works. But again, I think there's just more to it than that. And the clinical judgment of picking a good medication for the patient, matching a treatment with, hey, here's somebody that mostly wants to not take a med, but just needs something for certain days, and the clinical thinking that goes into that, are we really in healthcare like teaching that and transferring that the way that we need to be? I'm starting to question maybe not, and frankly, the length of time that we have, in any one patient interaction is also a limiter in terms of how well we, communicate and think.
Sure. And one of the things that's frustrating, I like to say frustrating, but one of the things that's frustrating is I go in with like a detailed like printout of all of the things that I've been through, my diagnosis, timeline, things I've tried, things that have worked, things that haven't, so on and so forth. And I'm like, please don't come into the room until you've at least like looked at this one page that I'm giving you. It's almost like my own personal healthcare media kit, like my own PR for my health. And I'm like, here's Lyndsay. And I'm like, okay, did you look at this? And he's like, oh, well, my whatever, whoever didn't give it to me. And I'm like, oh my God, just can you read this without asking me 72,000 questions over and over again when I've just answered all of them? So now we've taken 15 minutes answering questions I've already provided you answers for, when you could have spent some time actually getting to know me a little bit. And I know I'm a lot, but I'm a fun pain patient. I'm not going to lie. I am fun, and I would be stoked to be my doctor. Because I look at things in a different way than a lot of pain patients do, where I've just got this optimism that's in me. I have my days where I'm like, fuck it, I'm out. I can't do this anymore. I do. And I reach out to my personal board of directors when I have those days, and I say, hey, this is where I'm feeling. I'm hopeless. I'm lonely. I'm this, I'm that. I don't want to be here anymore because I can't put up with this kind of pain. And then they immediately shift me back into gear. And then, 5 hours later, I'm good to go.
Yeah.
Yeah. Do you deal with a lot of issues with your patients in regards to like suicidal ideation? What do you do in regards to that with your practice?
Yeah, it's challenging.
Yeah.
It's not, it might be less often that a patient also divulges that, frankly, right? Because, and I think there's something called like passive suicidal ideation when you're like, well, if I was dead, that might be better, but you're not really planning to do anything about it.
Yeah, that's me.
Right?
Yeah,
And
I'm like,
so
why don't I just go away? Why don't I just go away? It would be so much easier.
Yep. A lot of people have some kind of low level of that.
Yeah.
That we probably don't talk about a lot. And frankly, I would say I probably don't ask because, it's kind of more in that mental health realm where I'm going to start referring you to those folks. So I think we don't necessarily draw that out, if I'm honest. But I know that patients sometimes are feeling that way, when they're really challenged and when things are bad. I did have a patient lately who had gotten to that point and really actually had voiced with, was a young person in her early 20s that lived with her parents and had voiced some of that to her mom. And I ended up speaking with her doctor who referred her to me. And, we kind of worked together to get her in some other treatment right away. So that's been, I think the things we do, it is just taking those next steps. So communicating with other doctors, suggesting treatment. I have another patient who's voiced some of that passive suicidal ideation that's in a workup for ECT actually, and going to maybe go down that road of, just more in-depth mental health treatment with a strong mental health provider in our area.
Yeah. And I think that, with chronic pain, our brain changes, I mean, we change. I know that I am a very different person than I was a decade ago.
And there's imaging.
Not just because I'm older.
There's imaging evidence for that too, that patients in chronic pain have loss of some of the, cortical matter of the brain, frankly, that it's very taxing on the brain, that brains of patients with chronic pain do change over time.
Yeah, especially when you're kind of like a brain like me that still thinks that I am a downhill ski racer and I'm a yoga instructor and I'm hiking and biking and walking my dogs and doing all these things. That part of me is all here. I can't do any of it. Not yet. Not yet.
Not yet.
We're working on it, baby.
Yeah. No, and the optimism.
That's why I'm here.
Yeah.
I mean, I'm here for everybody that's listening and I'm here for you too. But the reason I started this was because I'm going to get out of a wheelchair and I'm going to do all the things that I want to do again.
Yeah.
Right. And so those low days that are very, very sad and very scary places, those thoughts have come up. And it's something that's fairly new, but I know that a lot of medications can cause those thoughts as well. And I experienced that early on in my pain treatment with a pain doctor in Los Angeles who put me on every tryptolene family medicine that they possibly could. It was touch and go.
Yeah.
And I'm like, I don't want to kill myself. Why do I feel like killing myself? I am way too awesome to die right now. This is ridiculous. And so that scary part is part of living in pain too, because you go in these dark and twisty places that you never would have thought was even available within you.
Yes.
Are there within the CDC? I'm sorry, I'm going to take a swift change really quick. When it comes to the CDC and prescribing and all of these medications, what are they doing as far as guidelines in regards to you guys prescribing for us? Are they good for the patient or are they good for the pharma?
I don't even know who they're good for. Gosh. I mean,
good answer.
Who is it good for? Maybe nobody.
Yeah.
I think the CDC guidelines of 2016 were very well intentioned, and they were really trying to say hey, let's move prescribing. Most patients should be not in a high dose opioid situation. Let's start with low doses. Let's refer people to treatment if they have a problem. A lot of the basics are pretty reasonable. But
Sure.
Then they got interpreted in such a way that these are absolute rules. And the CDC guidelines of 2016 were then put out in a revised form in 22, where they literally had to say, these guidelines are meant to be for the physician and the patient, and it's not for insurances, and it's not for state boards of medicine. And they really had to kind of come out and say that, because it suddenly was a very easy crutch, for a regulatory body or for an insurance to just be oh, great, we don't need to pay for any opioids over, 90 milligram morphine equivalents anymore because these guidelines. So why don't we just do that and save ourselves some money? It seems to me that was an easy thing for, a for-profit entity to incorporate to save a little money. And so, and the guidelines weren't meant that way, but in some cases, that's how they were interpreted or tried to be used.
Well, it's we can interpret the Bible as many ways as we want to. I mean, any story, anything. Any fable, anything, we can put in anything we want to in between the lines.
Well, I would say, for doctors who didn't want to write any opioids anyway, right? There are doctors who are out there that just want to do the procedures or just want to do the infusion or do the implant or whatever. And look, that's fine. But just, for those doctors that are hey, I don't write opioids in my practice, at least hopefully if they're upfront about it, right? Because there are doctors that say that. But I think where it gets challenging is there are all these doctors that do it, but maybe they hold their nose, or they don't want to, or they don't want to engage with it, or they don't believe that it works, for some of those people, those types of guidelines could be used, also as like an excuse, like, hey, well, we're only doing XYZ in the practice because this is what the CDC guidelines say. Well, okay. And ultimately, one of the challenges that I have, is, as a prescriber, we should, I should, prescribe in accordance with, what I think is beneficial to the patient. And it's not necessarily just what the patient thinks is beneficial to the patient, right? And so and there are times we might or might not be able to find common ground. If the patient thinks something is beneficial that I don't truly think is beneficial for them, there are going to be times we might not agree.
So you're ethical. Weird. It was like super weird. So you're saying that when I go into a doctor's office, I'm not necessarily always right.
Yeah.
That's
but hopefully
news
we
to
can
me.
find common ground and
Sure.
understand each other, or even, maybe we agree to disagree on one or two things. I think it's challenging sometimes, though, right? Patients and doctors to find that common ground. And yeah, really my point, I think, is really just that I think the CDC guidelines have been kind of scapegoated as, hey, this is the whole problem. We've got to obey these guidelines. And it's not exactly that. And doctors are supposed to use their own clinical judgment when treating patients.
Yeah. And I think that, again, to support the whole idea of like, we know our own bodies far better than our doctors do, but we also don't know what we don't know. And, I've learned, I'm a huge researcher. I mean, I have to be in order to even just do this show, but I also should have like medical degrees on my wall because of how much information I come to a doctor with. And I'm like, so I want to know about low dose naltrexone. Why have I not known about this for 8 years with CRPS? Just found out about it. What? Like it drives me bonkers. And I'm like, it's such a tumultuous road that you have to walk on. And I really want to make sure that everybody does have hope here, because people like you that love and are here to really educate us and give us tips on how to communicate, because I think that's the biggest thing. I'm like, okay, maybe I've been doing this all wrong on how I communicate with doctors. I just gave up. I stopped. I'm like, I'm not going to a doctor. I don't even know the last time I went to a doctor outside of like labs and emergency urgent care kind of thing, because I moved into functional. And it's expensive as hell.
Yeah.
Because our healthcare system won't pay for it. But that's the only place that I've started to see benefits in my life.
And some of that functional medicine concept to maybe do specific testing on how your body works and optimizing nutrition. Yeah, I'm a fan.
Yeah, and how it responds to things. Because with you, I mean, there's got to be sensitivities and reactions that come with pain medication and anesthesia.
Right.
And that's different for people. How do you broach that?
We're not there yet for the science of like the genetic testing to be entirely useful in the field, right? Because so imagine this, you've got like, they were talking about a medication and how does your body process it and how do you feel when you take it and how does your pain respond to it? The trouble is like our output with pain, it's not an objective number like a blood pressure, right? We're just like, we can then take your blood pressure after that pill and that bigger dose and we know like, here's what it did. And there's so much that goes into how you feel and okay, there's the pain score number and yeah, we ask people about it.
Are you a frown face or are you a flat face or a happy face? Super scientific.
Yeah. And like, what science will tell you might be more impactful and what patients might tell you be more impactful is like, well, what can you do? How's your functional status? Like, well, I was doing okay, like walking to the mailbox. And then the last 2 weeks, my hip's been really bad and I can't do that. And so the part from the processing of the pill by the body to like what it does to your brain part and how you feel, the measures on that end are so non-existent that we can do those, right? We can do those genetic tests and get some information. And I think they are useful sometimes in psychiatry and for titrating certain antidepressants. I think they can be informative for those providers. But, for me, it's just not ready for prime time in pain management. Sometimes patients will come to me with those results, but it doesn't necessarily mean we, will or won't prescribe you a certain thing.
Before we wrap up and everything, I one of the takeaways that I had with you in our meet and greet was you leaning towards this whole idea of focusing on the yeses in our lives when it comes to pain management. So can you speak to us a little bit about your philosophy on that? Because I think it was pretty cool.
Thank you. Yeah, I think, sometimes there's, like you said, well, this medication doesn't work for me, or this thing doesn't work for me. And finding, shifting to where we can find things that do work, things that are helpful for how we feel. And that may be things in our lifestyle very often. I think that, in terms of helping patients with their lifestyle management, it's really those like 5 factors of well-being. Just briefly to mention those, like sleep, diet, movement, community, and stress, and helping patients manage those items can be so impactful for chronic pain.
Yeah, and that's a lot to throw on just a pain doctor.
It is, yeah.
So that's why we do need that community. We do need that support network. I am here right now as a support network for you. I am here for anybody that listens to the show that just wants to. I get more like Instagram messages and emails and stuff, and it's getting more and more, which I'm so grateful for, because it means I'm touching at least one person every day.
Yes.
Oh man, I want to talk to you forever.
Yeah, so much to unpack.
But we can't.
Well, thank you.
Of course, it has been so wonderful to be here with you today. So we can find Dr. Merritt all over the place. She's on Instagram at LifestreamHC. She's on Facebook at Livestream Health Center. I'll put this all in show notes, of course. And on social media, she's on YouTube. She's on Twitter, aka X, whatever, LinkedIn. But her website you can go to first and foremost, where you can get all of this information about her practice, is lifestreamhealth.com. And as you've noticed, she's incredibly wonderful. And one of the things I love about your speaking voice is you make me feel calm. And as somebody that never feels calm, clearly,
good.
It is nice to have a conversation with you, because I feel safe with you. I know a lot of people that live in pain deal with a lot of fear of unknowns, and you don't make me feel scared. So
that's good to hear. Yeah, no, I think I would just share this candidly. I think there are these folks in pain medicine that don't love it. And I've come to start trying to communicate this to patients and really to doctors. Like, you've got to have your own head on straight to do this type of practice. And so for me, my own journey of just getting my head in the right position, I think can really help patients co-regulate and, get to a better spot.
Well, yeah. And trusting.
Yep.
Yeah. It's a big part, is trusting. And when you've gone through doctor after doctor after doctor and surgery after surgery and pill after pill, you start to lose hope and you start to lose faith in the people that are supposed to be helping you along the way,
Right.
But that's why we're here, to say that we've got people that are out there that can help you guys. All right. So don't ever give up on you. Don't ever give up on your life. Don't ever give up on your pain management journey, whatever that pain might be. This was a physical conversation more so than a mental and emotional, all of that. But guys, it all kind of falls together. Pain is pain is pain. Love is love is love. And that is all we are here to do today. So thank you so much for being with us today. I appreciate you. It's been wonderful to meet you. And I can't wait to see what you're coming up with next.
You're amazing. Thank you for what you're doing for the community.
Oh, thank you so much. You are exclusively invited to share this falling in love again with pain management, VIP pain journey together. Let's get to the heart of how to heal with you by my side. Is there anybody today in your life that needs to hear this conversation? Or did you need to hear this conversation? Are you feeling lonely? Are you feeling hopeless? Are you feeling sad? Are you feeling there's absolutely no way you're going to get through it? Please reach out to us. Welcome to the Pain Game Podcast. That's what we're here for. So let's connect. Let's hear your stories of strength and grit and merit. See what I did there? I am here to help provide a safe place for you, of vulnerable and raw and open and honest, to share your most incredibly powerful stories. So follow us at the Pain Game Podcast, wherever you digest your podcast content. We will be there. Visit us at thepaingamepodcast.com and follow us on all the socials. Thanks for listening, my little VIPs. Catch you on the other side.